Two, one. Sir, we are live now. Now we can start.
So thank you, Maharshi, for allowing us to do this. And we have today fourth session on tumor module, and we have Dr. Mihir Thacker from US. Mihir is a great friend of us, and he has phenomenal work in tumors. And I'm sure that all of us would learn from him how to deal with the pediatric malignancies. Joyance, all for you. Please introduce the speaker and get the ball rolling.
Good morning, everybody. I'll just introduce Sir, and then we'll go to Sir's talk. Mihir Sir is from Nemours Children's Hospital in Wilmington, Delaware, and Sir did his orthopedic residency from Lokmanya Tilak Municipal Medical College and Hospital, and followed by his musculoskeletal oncology fellowship from University of Miami and pediatric orthopedic training from Nemours and from Hospital for Joint Diseases. And Sir's area of interest and expertise are orthopedic oncology, pediatric hip disorders, skeletal dysplasias, and limb length abnormalities. And we are very privileged to have Sir join us today. So I'll just stop my share. Sir, you can share your screen and we can start.
That was very kind of you. That was a very nice introduction, both from Joyance and from Molin. So thank you very much for the invitation to be here and share some of what I have seen and some of my work with you. And it'll be a good time for us to discuss things related to malignant bone tumors. So let's see. Okay. Can you guys see my screen okay now?
Yes, sir. Yes, sir.
All right. So, we'll kind of very briefly touch upon some of these basic things with malignancies. And what really makes a tumor a malignant tumor is two basic qualities. One is it has unrestrained growth, and two is the ability to metastasize. So malignant tumors have certain special characteristics that allow them to kind of escape apoptosis and continue to grow and kind of disregard the growth inhibition signals. And they also tend to bring in lots of blood supply, which then becomes important from a surgical treatment perspective, because then things are very, very vascular for the most part. And the good thing about pediatric bone tumors is that benign bone lesions are way more common than malignant ones. So that's a good thing, but it's also something where you do have to be careful, because you cannot assume that everything is going to be benign and then you run into trouble with the malignant tumors. The most common, as all of us know, is osteosarcoma. Ewings are the next most common. And then there are some less common things. So we'll talk about the common ones. We'll talk about some basic principles of how do you evaluate, how do you manage, and then we'll go over some cases if we have time. Now, some of this, as Molin pointed out, you have covered over the last 3 weeks. So I will probably run through it fairly quickly. And if anybody has any questions, please feel free to stop me at any point. From a diagnosis perspective, remember CPR, right? So that is clinical pathology, radiology, correlation. And all three things need to kind of add up. And that is then what makes the picture complete. If something is not adding up there, then we are missing part of the puzzle and probably heading down the wrong path. Now, from a history and physical exam perspective, things that are warning signs, as we all know, are night pain, rest pain. The one thing to understand and appreciate here is even when you look at malignancies, osteosarcoma, Ewing sarcoma, by the time you reach this night pain stage, it is pretty far along. To start with, these, just like every other oncologic and non-oncologic lesion, will present with mostly activity-related pain, where there's bony insufficiency and you're loading an insufficient bone, and that is then going to cause pain. What is different is that pain is unrelenting. So you have pain that initially may have some sort of a response to simple non-steroidal anti-inflammatories, but the response is really not as good as you typically would want to see. So that is a red flag. Any constitutional symptoms obviously are red flags. So, things like fevers, night sweats, things like that, you want to think in terms of infection for sure, especially in the Indian context. You always want to think of tuberculosis and infections, but you also want to keep in mind that there may be some oncologic process. So it's all about having a high index of suspicion. And from a physical exam perspective, again, by the time you see a tumor that's big, that you can see on the screen there on that picture, obviously it is pretty far along. So you want to try and catch things well before they reach that stage. So what do we start with? Once we've got a good history and a good exam, figure out whatever method works for you from a systematic radiographic approach to these bone lesions. And I'm sure Aditya Daftari did a great talk on this. So this is kind of just a little bit of my version of things is, we look at all the 4 Enneking questions. Where is it? What is it doing to the bone? What is the bone doing to it? And is there any identifiable matrix? And then I look at whether it's a single lesion, multiple lesions, whether it's an osseous matrix, chondroid matrix, fibrous matrix, or something else. From a benign versus malignant perspective, it's not always straightforward. The most important thing is going to be the zone of transition. So that is the junction between what is affected bone and unaffected bone. If it's a very sharp demarcation, then you know that you're dealing with a process that is not biologically very, very active or aggressive. So those are good. But if you cannot really say, okay, this is where it starts, this is where it ends, then that's a pretty broad zone of transition. And those are the ones that are going to be biologically the more aggressive lesions. The other thing to always kind of keep in mind, from an exam perspective, they always talk to you about whether or not you see a sunburst reaction or whether you see onion skinning. Sunbursts you often see in osteosarcomas, but it does not mean that all sunbursts equal osteosarcoma, and it also does not mean that all osteosarcomas will have a sunburst appearance. So just keep that in mind. Same thing for onion skin. You can see that in infection. You can see that in other things as well. So while it may be suggestive, it is not always diagnostic. If you look at the forearm X-ray in the middle of your screen there, you see what we call a Codman angle or a Codman triangle, which is basically just periosteal elevation and new bone at that angle. And then you see what looks like a sunburst reaction, so a spiculated periosteal response. So you would say, okay, this is probably osteosarcoma. You see some sclerosis and all of that. But this is actually a patient with Ewing sarcoma. So even though you have the so-called Codman angle and the sunburst and some degree of sclerosis, pathology becomes important, and you really want to establish things from a histologic perspective. So when you look at your imaging strategy, always, always, always start with plain films because they give you the answer probably the majority of the time, or at least they give you the direction the majority of the time. So they're helpful not only with diagnosis, but like we talked about, with what the biology of the lesion is. How aggressive is it, right? From a Cross-sectional imaging perspective, very rarely do we do CT scans these days, although I have an example of a CT right there for you. We oftentimes end up resorting to here, the reason why I put this CT up is because on this CT, you can see a nice example. This is a 6-year-old that came in with a pelvic lesion, and you can see on the left side a nice lamellated periosteal reaction. So this is your so-called onion skin. And also what you see is, look at the soft tissues on the inner table there versus the inner table on the left side. You can see there's a large soft tissue mass, both on the inner table and then a smaller one on the outer table as well. So this is very typical of a Ewing sarcoma round blue cell lesion. So from a staging perspective, anytime you're dealing with a malignancy, you want to get your local extent, which is with X-rays and then MRI. Typically for an osteosarcoma, you're going to get an MRI of the full length of the bone to look for skip lesions, and we'll talk about those again as we go along. And then you also want to do what is called distant staging. So you want to see if it's spread elsewhere. And the most common place for things to go as far as malignant bone tumors in the pediatric population are concerned is they will go to the lung or they will go to other bones. So typically, you end up with a chest CT and you end up with either a bone scan or a PET scan. For Ewing sarcoma, you can have bone marrow only metastasis. So you also want to get a bone marrow biopsy. So those are some of the things that you look at when you do your staging workup. But you always want to prove your diagnosis histologically. And biopsies can either be needle or open, and you've had a session on biopsy as well, so I will not belabor the point. Basically, in today's day and age, for the most part, we end up with needle biopsies, and it has to be a core biopsy. FNAs are almost entirely useless for bone malignancies. Open biopsies, we still do sometimes, but for the most part, like I said, it's usually, at least in our situation, going to be a needle biopsy. Whether you do the needle biopsy or the radiologist does the needle biopsy is really more kind of situation dependent. As long as you have the ability and the facility, you can certainly do those yourself. This obviously is not a great biopsy, and it's not a great biopsy because number one, you can see it's transverse. Number two, you can see a large kind of draining wound there, and then you have a big hematoma that's spread all the way up. So that means that tumor has seeded all the way up the thigh, and now you're going to end up with an amputation instead of something that could have been easily resected. So try and stay out of those kinds of situations. Once you send the biopsy material off, then your pathologist needs to be good enough to tell you what it is, what is the subtype, and how aggressive it is. And they have their ways to do that. And, you know, if you're dealing with tumor, then you really want to be familiar with how to send your specimen and how to talk to your pathologist. But even if you're not dealing with tumor on a regular basis, the important thing is communication. And you really want to, before you do the biopsy, discuss the case with your radiologist and discuss the case with your pathologist so they know what's coming, they know what the clinical scenario is, they know what the imaging scenario is, because again, you want to do your clinical pathologic radiologic correlation, right? Okay. And, you know, staging typically is post biopsy. So you want to know what stage it is. For the most part for us in the pediatric bone malignancy realm. Both osteosarcoma and Ewing sarcoma are considered high grade, so you're looking straight away at a stage 2. And whether it's intracompartmental, which means restricted to the bone itself, which is uncommon, that would be a stage 2A. Or if it's outside the bone, which is much more common, then that would be a stage 2B. So that's extracompartmental. And then if you have a skip lesion, it becomes a stage 3 for the AJCC. And if you have metastatic disease, then that is a stage 4 AJCC or stage 3 anarchy. Okay. Treatment is teamwork. And it is a combination of your medical oncologist plus you. And if you're dealing with Ewings, then maybe you bring your radiation oncologist in as well. And for bone malignancies, typically for both Ewings and for osteosarcoma, treatment after you've done your biopsy, established the diagnosis, and staged it is going to be neoadjuvant chemotherapy, which means chemotherapy prior to surgery, then surgery or local control. Local control in Ewings can either be surgical, if you can get a wide margin, which we'll talk about momentarily, or it could be radiation, especially if it's a spine or a big pelvic primary, then you can treat those with radiation as well for Ewings, not for osteosarcoma. And then they get more chemotherapy. And nowadays, there are many more options other than traditional chemotherapy as well for some of the more obstinate tumors. So there's a lot more of immunotherapy and, otherwise genetically targeted therapy based on mutation. So part of pathology today is to send the material off not just for your regular H&E exam, but we also send it off for next-gen sequencing to see if there are any actionable mutations that we can use to do targeted therapy. As surgeons, what is important to us is resection, and you want to, at the very least, shoot for a wide margin, understanding that depending on the situation, frequently our margins are going to be marginal. So what does that mean? When you look at margins, margins can either be intralesional, which is self-explanatory, you're in the lesion and you're curating it out, which is never what you want to do for a malignant lesion. You can be marginal, which means through what we consider the reactive zone around the tumor. Ideally, you want to be at least wide, which means away from the marginal area, away from the reactive zone, and through normal tissue. Usually for bony margins, we prefer to get at least 3 centimeters up and down. And for soft tissue, we prefer to get at least 2 centimeters if we can. Usually, if you're talking about a distal thermal osteosarcoma, frequently they will, by the time you see them, there will be enough soft tissue extension that they're right up against the vascular bundle. And in that case, it's impossible to really get a wide margin without sacrificing the bundle, which is not what you want to do. So in that situation, you end up with a marginal margin, and you can take the adventitia, strip the adventitia off the vessel, and the adventitia is actually a good margin tissue. So different tissues have different resistance to tumor. And, fat traditionally will allow things to come through pretty quickly. But if you have adventitia of a vessel, then that is much more resistant to tumor coming through it. So that is what we would then consider to be a reasonable area to have a closed margin in. Back in the day, we used to resect entire compartments of muscle that were involved with the tumor, and that is what we call a radical margin. Very rarely in today's day and age do we end up with a true radical resection. So for the most part, you're shooting for a wide margin and you end up with marginal margins for the most part in many areas, not in the entire extent of the tumor, but in many areas. So at the end of the day, what do we want? We want, number one, to make the right diagnosis, because without that, your treatment is going to go completely haywire. So get your imaging, get your biopsy, get a good pathologist to tell you what it is, and that way you can then create the proper treatment algorithm. Then you do your neoadjuvant treatment, and then surgery for us. The question becomes, when do you amputate? When do you salvage? Is salvage as good as an amputation from an oncologic perspective? What kind of margin are you going to get? And then how are you going to reconstruct the bony defect, how are you going to reconstruct the soft tissue, and then how are you going to follow them along. So let's go through some of those. Surgery for malignant tumors in the pre-chemotherapy days, so in the 70s, 60s, 50s, was mostly amputation. And despite amputation, they found that for osteosarcoma, the 5-year survival was as low as 10 to 15%, which is pretty awful. So chemotherapy is really what made the biggest difference in the overall survival of osteosarcoma. So in the 70s is when we came up with chemotherapy for osteosarcoma, and then kids were surviving longer. So then people started looking at, okay, do we need to amputate? And if we don't need to amputate, how do we salvage the limb? Mike Simon from Chicago in the 80s had a seminal paper that talked about the oncologic risk of amputation versus limb salvage. And he was the one who showed that limb salvage tends to work just as well as amputation from an oncologic perspective. There may be a minimally higher local recurrence rate, but overall outcomes were very similar. So we moved from almost exclusive amputation to, in today's day and age, almost exclusive limb salvage. And for limb salvage, from a bony defect reconstruction perspective, you can either use bone or metal or a combination of the two, and we'll go over some of those. We'll also talk about amputations and a little bit about rotationplasties and tibial turn-ups. Okay. So amputation in today's day and age, when do we do it? Number one is if the neurovascular bundle is just not salvageable. And even in those, sometimes if you can preserve nerves, then you can do a vascular reconstruction and get away with that as well. So the indications for amputation have really kind of narrowed down over time. The other practical reason to think of an amputation is if what is left after you've done your resection is not functional, then there really is no point in preserving the rest of the extremity. So if you have a tumor that has so much soft tissue extension that there's going to be no useful muscle left, then you really want to consider or reconsider limb salvage versus amputation, and really want to think about amputation in that situation. Because with the advances in prosthetic reconstruction today, the function after many of these amputations, especially with the Bijlani ones, are excellent and durable. So amputation is not as bad from a recovery and function perspective as it used to be, 30, 40, 50 years ago. Relative indications are if you have major involvement of the sciatic nerve, or if you have pathologic fracture, or if you're going to have trouble covering things. But with plastics these days, you're able to get most of those things sorted out. Okay. So let's talk about salvage. When you talk about salvage, you can either salvage the defect with bone. If it's a small defect, if it's a skinny bone like the ulna as you see in this situation, then you can use a vascularized fibula. You can use a vascularized fibula by itself, or you can use it in combination with an allograft, which is what we call the Campagna technique. And that gives you both the structural stability from the allograft and the biology from a vascularized graft. Limitations are obviously size, because you can only have that big of a fibula. So if you're reconstructing a big femoral defect, then you may have to do a double barrel fibula, which then adds a lot more to the time and also to the complexity of the surgical reconstruction. Allografts, which are basically bone from a cadaver, come in various different flavors, so to speak. You can have something that has the joint surface, which is an osteoarticular allograft. So, as you see in the picture the pictures at the top, we have two examples there. On the middle image, you see, or on the image to the left of the screen, you see a fibula that I'm using to reconstruct a defect after resection of a distal radial osteosarcoma. In this case, the boy was only about 9 years old, so finding another distal radius to match was a challenge. So size, especially in the pediatric population, can be a significant issue. Also, if you think about it, if you have to match something, it has to come from a cadaver. It has to be from someone their size, which means another child needs to have died. And the family needs to be okay with donating their organs, which is a little bit morbid and not always easy emotionally. So you do run into challenges and you have to be a little bit creative. So here, in this case, we did an osteoarticular contralateral fibula, which kind of looks similar to a distal radius. And you could have used his own fibula as well. So that's always a choice. Yeah. So osteoarticular allografts for places where you don't really have great options from a metal perspective. For knees, you have very good metal options. For shoulders, you have very good metal options. For elbows, you have reasonable metal options. For ankles, you have not such great metal options. For the wrist, you definitely don't have great metal options. So for the areas that don't have great metal options, you really want to think about more of an osteoarticular allograft. But this is fortunately a small percentage of what we need from a reconstructive perspective. Intercalary allografts are used quite frequently and they tend to do pretty well. So it's basically taking out a segment and then putting in an allograft in the middle. Alloarthrodesis is in situations that are more salvage. And there you take out whatever's in the middle. If you've done an extra-articular resection because the tumor involved the joint, then you want to fuse the joint. And usually in those kinds of situations, it's not just the bone, but you've lost or sacrificed a good bit of the muscle as well. So you're really not going to get great motion. And there you end up using an allograft to arthrodesis. APCs or alloprosthetic composites, we tend to use more so around the shoulder, occasionally around the hip, where soft tissue attachments are quite critical. So for the shoulder, you need to have a good rotator cuff attachment. And if you use an alloprosthetic composite, then you can suture the rotator cuff to the cuff on the allograft, and that gives you at least some degree of good soft tissue reattachment and retensioning. And then the articular surface is the one that tends to break down. So you replace that with metal and you still have some bone stock left over for your revision that will probably follow. So for allografts, the advantage is it's bone, so it's biologic. You can use it on just the one side of the joint and salvage the other side. And if you're using an APC, then you can use the soft tissues to reattach your muscles too. Disadvantage, they have quite a few complications. And the big thing is infection, which is about 10% or so, maybe up to 15%. And fracture in 20 to 30%. Infections typically happen within the first year. Fractures can happen anywhere in between, up to years 3, 4, 5, 6 even. So you're really never completely out of the woods as far as fracture risk is concerned, up until probably about year 5, 6, or 7. So you do need to be careful with those. So because there are so many complications with allografts, for the most part, whenever feasible, we tend to go with a metal option. And this is mostly for the older teens, not so much the 5, 6, 7-year-olds. There, you really want to try and be as biologic as you possibly can. And in the older teens, we do tend to respect their activity levels and they need something strong. They need something that will get them up and about right away. So for them, we do end up using more kind of metal megaprostheses to replace the resected bone. The Fracture risk is much lower. Infection risk is also a little bit lower. But just like every other total joint, they do tend to wear out over time, and they loosen, and they need to then be revised. So here's an example. This is my very first case as a young attending over at a different hospital. It's called Christiana. That's where I do some of my young adults, or where I used to do most of my young adults. Now I do as many as I can over at our place. But this is a guy from Pakistan and has a distal femur osteosarcoma. You can see the increased bone density, you can see the sunburst, you can see the Codman angle, all very classic. And pathology confirmed that it was an osteosarcoma. He had his staging studies, he had his neoadjuvant chemotherapy, and then we ended up resecting that and replaced it with a distal femoral replacement with a rotating hinge knee. Why do we use a rotating hinge knee? Because, as you know, the normal native knee has some degree of rotation to it. And when they used standard hinges without rotation back in the day, they found that all that torque was getting transmitted to the bone prosthesis junction, causing early loosening. So that is where they came up with the rotating hinge design. And that's what we've done for probably about maybe 35, 40 years now. You can also have holes for reattaching soft tissues. So this is a patient with a proximal femoral osteosarc with a proximal femoral replacement. In this case, we've done a bipolar. With the proximal femur, especially in the super young, you do have to be careful because you do alter their acetabular growth, and they end up with dysplasia and then oftentimes subluxation, because as you resect the proximal femur, your hip abductors are not great either, and that then over time can compromise your stability. There's an example of a total femur, so you can do all sorts of different things. Yeah. You can also use a megaprosthesis to replace a fractured allograft, or deal with the complications of allografts. We've talked about expandable endoprosthesis at the POSI meeting this year, so I will not go into those in too much detail. But here's an example of an 8-year-old initially treated with an intercalary allograft, ended up with a fracture 4.5 years out, put on an expandable, and then gradually expanded her out. So by the time she's skeletally mature, now we've lengthened her about 5.5 centimeters. She's level and happy. There's an example of an alloprosthetic composite. So you can see this is a proximal humerus, and you can see the rotator cuff on the graft. You prepare the graft on the back table, replace the articular surface, pop that thing in, and then repair the soft tissues and plate the junction. Okay, so metal is easy. It is easily available. It is modular, so you can adjust lengths. It has lower fracture and infection risk, but it's artificial and it doesn't incorporate, doesn't account for growth unless it's an expandable. And over time, it does wear and cause loosening. Rotationplasties are a unique reconstructive option, which we oftentimes resort to in the really young child, in the 4, 5, 6, 7-year-old. It is a phenomenal option because it is biologic. And what you're doing with the rotationplasty is you're converting an above the knee situation to a below the knee situation. And if you think about energy expenditure for an AKA is much higher than for a BKA. So when you convert this to a BKA situation, you end up with a much more functional foot. And if you have a 6 or 7-year-old, even if you did a metal reconstruction, number one, it will be quite small. Number two is, even with the expandables, there's a very high revision rate, and you do have to limit them with what activities they can do. As opposed to that, with a rotationplasty, they are running around doing all the stuff that you would do as a growing child. The only challenge, obviously, as you can see in the pictures there, is it looks strange. And, if it's a young boy, they don't particularly care as much, because they kind of are not at that developmental stage. But heaven forbid, if you try and do this in an adolescent teenage girl, be prepared for tons and tons and tons of problems, because from a developmental perspective, that's the time where their body image is super important. And you do something like this, unless it's a special family, you are going to run into trouble. So patient selection and patient acceptance are what limit you with rotationplasties. All sorts of different rotationplasties based on where you need to resect and what your primary tumor is. We won't go into those. We'll quickly run through some basic things about osteosarcoma. This is the most common primary bone malignancy in kids. You can either have a primary or a secondary osteosarcoma. Primary osteosarcomas is obviously where the bone is otherwise normal. Secondary osteosarcomas are typically in older people and either post-radiation or post-Paget's. And the prognosis for both of those is awful. You can have predisposing syndromes such as retinoblastoma or leaf-Raumeni, which is a p53 mutation, that then predispose people to osteosarcomas. So always ask for that history. It's important because if you do have those mutations, then they can develop other tumors as well. So you do need to refer them to genetics or have the medical oncology folks keep an eye on things for you. Traditionally, the histology is an osseous forming, high-grade conventional osteosarcoma. They can be chondroblastic, they can be fibroblastic, they can be telangiectatic, and some of them can be lower grade. So a low-grade example would be something called a parosteal osteosarcoma. Intermediate grade would be something called a periosteal osteosarcoma. So we'll see those in a moment. Osteosarcomas typically happen around the adolescent growth spurt. So 10 to 20 is a pretty high age of osteosarcoma occurrence. Prior to age 10, Ewing's is more common than osteosarcoma. Once you hit age 10, osteosarcoma becomes 3 times as common as Ewing's. Most of them happen in the appendicular skeleton. Only 20% of them are in the axial skeleton, which is good because it's really hard to then resect if it's in the axial skeleton. Histologically, like I said, most of them are osteoblastic, and then you can have some of the other ones as well. So here's an example of what we call a parosteal osteosarcoma, which comes from the fibrous layer, not the cellular layer of the periosteum. So posterior distal femur is pretty common, and you have it almost kind of stuck on. So if you take your chewing gum and stick it on the desk like we used to when we were kids, that is what these things look like. And they're low grade, so no chemotherapy for them, just resection. Then at the bottom, you see what is called a periosteal osteosarcoma. So it's all still on the surface. You can see the sunburst on the surface. The anterior proximal tibia, anterior distal femur are pretty commonly involved. And these are always chondroblastic in histology. Okay. Treatment is fairly similar to a conventional osteosarcoma. Prognosis obviously is a little bit better because it's intermediate grade. Then we talk quickly about skip lesions. So about 5% of osteosarcomas will have a separate area of involvement that is not continuous with the primary lesion within the same bone. That is what we call a skip lesion. And back in the day, we used to think that these were much worse. But if you resect the whole thing along with the primary, then the results are just as good as your primary osteosarcoma treatment. Once you resect things, you always want to watch them. So typically we'll bring them back in every 3 months for the first 2 years, every 6 months for the next year, and then every year for the next couple of years till you hit at least year 5. And then based on whatever reconstruction you've done for them, you may need to bring them in to monitor the reconstruction after that. As you're monitoring them, about 5 to 10% of them can recur. They oftentimes recur in the soft tissues. They will sometimes recur within the bone as well. If it's an early recurrence, the earlier the recurrence, the worse the prognosis. and the higher chance of it going elsewhere and going into metastatic disease. So local recurrence is bad. And as a surgeon, what you really want to do is get yourself a negative margin. That is your best protector against local recurrence and against overall prognosis in life. Metastatic disease happens in about 20% of patients with osteosarcoma at the onset. And remember, 20/20 for metastatic disease. So 20% have metastatic disease, and the 5-year survival is 20% as opposed to, 60 to 70% for osteosarcomas that are non-metastatic at presentation. So as far as prognosis goes, it really depends a lot on the biology of the tumor, which unfortunately you and I cannot control. It depends on what the response to chemotherapy is, which is a huge important predictor. And we'll talk about that on the next slide. Anything more than 90% is what we consider to be good tumor necrosis. The further away you are from the 90%, the worse the prognosis gets. And then from a surgical perspective, like I talked about, the important thing is going to be what is your resection margin, because that is one thing that you can control. You cannot control the tumor biology, you cannot control the response to chemotherapy, but you can control your resection margin. And it's important for us to make sure that we have a negative margin. Ewing's, younger kids, more axial distribution. And then you have a characteristic 1122 translocation, with the EWS-FLI1 being the most common fusion transcript. You have 922 and you have some other less common mutations as well. But 1122 is what you need to know from your testing purposes. Yeah. They can, as you know, present very similar to patients with infection. They can have fevers, they can have elevated white counts, elevated cell rate. When you look at the MRI, it may be reported as pus, and you really need to be careful and look at your clinical situation. Make sure that you biopsy things appropriately. If this is where that adage of biopsy what you culture, culture what you biopsy comes in, right? So very, very important from a Ewing sarcoma perspective. The other two things that I really want for you to take away, which are not necessarily your standard textbook teaching things, are number one, Ewing sarcoma can have a relatively benign appearance for a while, and then it kind of takes off. So you may have something that looks small, looks well circumscribed, looks like it's really not growing very quickly, and then suddenly something happens to it, and then it will explode. So be careful, because in those early stages, you may be fooled into thinking that it is something that is benign, and you may end up curating it out and then end up in trouble. Number two is, as far as Ewing sarcoma is concerned, if you look at this example, this is a really nice example of where your plain X-rays look reasonably intact, right? There's some change in the bone. You can see the change in the bone, but the bone itself doesn't look too bad. And then you look at the MRI and you're like, oh my goodness, there's such extensive involvement and there is a huge soft tissue mass. So this is very typical of round blue cell lesions, especially with Ewing's. So those are the two things that I want for you guys to take away with Ewing sarcoma, other than the fact that it can also mimic infection. Yeah. All right, so we've talked about this briefly. Age, younger for Ewing's, older for osteosarcs. Race is not that important for you in India, but for us, it's much more common to have African Americans having osteosarcoma than Ewing sarcoma. Location-wise, axial skeleton for Ewing's, more appendicular for osteosarc. Not that Ewing's cannot happen in the appendicular skeleton. The number one location for both actually is the distal femur, right? So just the fact that in the Ewing sarcoma patients, axial involvement is more common. From a location within the bone perspective, osteosarcomas are typically metaphyseal. Ewings are traditionally supposed to be diaphyseal, but you can see metaphyseal involvement as well. Yeah. And vice versa for osteosarcs, but much more common in the metaphysis for osteosarc and probably a little bit more common in the diaphysis for Ewings. Staging, the difference is you add a bone marrow for Ewings as opposed to an osteosarc where you just do your bone scan or PET and a chest CT. For imaging, you want to get the full length of the bone for osteosarc to look for skips. And then you look for your sunburst and Codman angle. For Ewings, you look at the onion skin, and we talked about why those are not by any means the end-all be-all. Treatment-wise, Ewings is radiosensitive, osteosarcoma is not. Okay. Other things, we'll briefly stop after this because I think I've gone a little bit over. And then we can go over some cases. If you have cases, I'm happy to do those. And if not, I have cases to show you guys as well. So this is kind of the end of the talk here. So lymphoma, involvement of bone is pretty common with the non-Hodgkin's lymphoma and oftentimes is multifocal. And just like you saw for the Ewings, you see, again, lymphoma as a round blue cell lesion. So if you look at the x-rays of the tibia looks relatively preserved, and then you see tons of involvement of the marrow. So again, you need to think about round blue cell lesions when you see that, okay? So in conclusion, a couple things. Number one, remember your CPR, so clinical pathologic radiologic correlation. Make sure that things add up. As always, infection, leukemia, and LCH will look like just about anything under the sun, so they should always be on your list of differentials. And then it's all about principles. When you look at these, make sure you image them properly, make sure you biopsy them properly, and then you can take care of whatever the pathology shows. It's always going to be multidisciplinary, so you have to have good communication with the team. Have a good radiology friend, have a good orthopedic oncology friend, so that way, if in doubt, you have someone to fall back on. Having said that, radiologists are very nice, not always accurate. So you have to look at your own imaging. Okay. And that's it for now.
Yes. So that was a great talk, Mihir, and pearls of wisdoms were followed. Now, one question comes to my mind, like many a times we see that the tumor is being treated and that is going through the physis. And we know that we do not have that excess of expandable processes every time. So we know that this child would end up into limb-length discrepancy. So should we treat that discrepancy at the same level? Or when we are dealing with tumor, you just don't treat any virgin area for that time and come later and treat? How do you deal with it?
So that's actually a great question, Maulin, and it's actually a multi-layered question. So I'm glad you brought up the physis because I did not get into that. You know, traditionally, the thinking was that the physis is a great barrier for tumor. That unfortunately is not true at all. If you have extensive abutment of the growth plate by the tumor, almost invariably the tumor will go through that growth plate. So when you talk about physeal sparing resections, you really don't want to try those when the tumor goes up to that growth plate. You really want to do those only if you have enough margin in between the tumor and the growth plate. So that's one thing. Then your question of whether or not you want to deal with the limb length discrepancy. Limb length discrepancies are a problem, and they're a problem for multiple things. When you're looking at, let's say you're doing a distal femur resection for whatever tumor it is, and you're taking away the distal femoral growth plate, you are going to end up with a limb length discrepancy based on how much growth you have remaining. Now, whether or not you deal with it at the same time as your operation for the tumor is concerned is a little bit dependent on what you're doing for the tumor. If you're going to do something like an allograft, which then means that you're going to be non-weight bearing on the tumor side, then you want at least one good leg to stand on. In that situation, you're probably better off deferring the epiphysiodesis. If you're doing something that has, something that you can walk on right away. So if you're doing a metal endoprosthesis, you can do it at the same time. If you're doing it at the same time, understand that you're probably going to get more chemotherapy after. So you want to then do something that is going to be less likely to get infected, less likely to have trouble. From an epiphysiodesis perspective, out of personal experience, I will tell you that if you end up doing something like an 8-plate for epiphysiodesis, once they get off of chemo, they do end up with somewhat of catch-up growth, and they grow right through those 8 plates. So in my hands, I have not had great success, and I've actually abandoned doing 8 plates in those situations. So then you're looking at a drill epiphysiodesis, which means then you have to be careful with fracture risk and all of that. So you have to time it a little bit later. That would be my suggestion for the most part.
The second question is, it's like, of course, I don't do tumor practice, and then I involve adult oncosurgeons, but I have seen and witnessed Sevan in sick kids, Every time he'll receive a message about secondary or failure of primary reconstruction, the whole day will be off kind of him. So how difficult is this tumor practice, especially in dealing with young children? Or how you cope up with that,
That's a tough question. I can tell you the surgical failures are obviously disheartening. I just last Friday, so a week ago, I lost one of my patients. She had NF1, had a malignant peripheral nerve sheath tumor that developed on one side. I ended up doing a above knee amputation for that side because it was just too extensive to resect. It was in the sciatic nerve. Then she ended up with a large metastatic lesion in the contralateral femur with a pathologic fracture. So I ended up resecting that, put in a proximal femoral replacement. And probably 3 or 4 months after that, she ended up with massive lung mets. And she passed. Now, this is surgical failure plus life failure, right? It's tough. It is absolutely depressing when you hear these things, when you go through these things. You've been with the family for a while. They know you well, you get to know them well, and you suffer with them, right? Every time I lose a patient, it's like losing a little part of my soul. It happens to all of us. You just have to, fortunately for us, in peds, there's nobody who does only peds tumor. There's always something else. So that is our buffer. And that is what you use to kind of get out of some of those difficult emotional situations.
Great. Now, one more question is, as I work with Mandeep, we do a lot of intercalary resections and radiation and putting it back with this 3D model plates. But many a times when we deal with the proximal femoral tumors, when you try and fix the intertrochanteric region, sometimes there is an AVN of the neck area and fixation is lost. So we are dealing with one such child who is 3 years survival of Ewing sarcoma. And there is first it took an AVN and then physeal slip. Now the AVN has resolved the head side, but the neck has resolved. So we are clueless at what to do because that is a radiated bone. So you cannot do an valgus osteotomy. And child is almost 4.5 years old. So how you would salvage that situation? Now, the screw, the proximal screw in the plate is about to impinge the acetabulum. It is not yet. Child has good range of motion walking with it. But Mandeep is not, he was to present this case, but he had some schedule. But this kind of situation comes. So we are just waiting and see how things go.
Yeah, that's a tough one. I mean, that's a tough one on multiple levels. I think in that situation, what probably is the only thing that might, I shouldn't say only thing, but one of the things that has a slightly better likelihood of working is a vascularized graft. So whether you do a vascularized fibula or if it's a smaller area, then you can do a vascularized iliac crest. But it sounds like if the whole neck is resorbed, then you're probably better off with a vascularized fibula. Because if you do a dead fibula, again, in that radiated bone, radiated tissue bed, it's going to be a challenge. So in that situation,
So if
probably.
we want to do some corrective surgery through an irradiated bone, that should be done after how many years of primary surgery?
I don't know that there is a true recommendation for what the interval needs to be. I think it really depends on, what your bone quality is at the end of the day. But I don't think that there is any time recommendation that at least I'm aware of.
We should use the vascularized grafts, as you say, to.
Whenever, if it's a big defect, then yes. And, as you pointed out, going in for surgery with appropriate counseling and appropriate caution, not necessarily just doing whatever we would do in other virgin situations.
Great. Joyance, if there is any question come up, so let us know. But it's 9 o'clock. We are right on the time. So, Joyance, do we have any questions? I at least in chat box I didn't see any. So I think Mihir, that was a great talk. This recorded video will be sent to all the fellows and they would see, and OrthoTV also telecasting it on their channel. So I'm sure a lot of people will be benefited. And thank you very much for your time.
Thank you for having me. And I'm sorry I went on a little bit long, but if anybody has questions at any point, more than happy to go over stuff.
Right. So I think we shall conclude today's session, and thanks, Mihir, and we'll catch up with you in regarding POSICON soon. It's coming up well. We are getting good number of registrations, and I hope that will be a good show as well.
I'm sure it will. I'm sure. With you organizing it, we expect nothing less, Molin.
Yeah. Okay, Mihir, thanks for your time.
Question for you, not related to the tumor side of things. Are you shipping your spiker table outside of India?
Yeah, like I have got an order from this Buddhadev, or what's his name?
Yeah, Pranay.
Pranay, yeah. So he wants, he has ordered 15 tables for Africa mission trip. And for overseas transport, we are charging 8,000 rupees per table.
Okay.
It's not.
Yeah, I was asking mostly for that as well, because I am going to be in Zambia right after POSNA. We're doing a course, POSNA, BISCOS, and COSEXA. We're doing a course for the African residents.
So Pranay has someone coming from India to Africa. So he said that he will carry. So I do not have to courier it. And I do not know the overseas courier charges so far. We have been doing it across the India. But you let me know. I mean, there must be a way. We do a nice tracking, and I presented this in iFix. So 5 people in iFix, they want to buy. So it's a very niche and very simple sort of design. and we have been using it for 15 years now. I'm got it. We have applied for a patent as well. So
Nice.
yeah. So let me know, and we can help with it. I saw this counterpart. My lawyer brought 2-3 designs which are, and there's a went through the net, and they are costing $30,000, and one was $10,000. So I mean, it's very simple design, and anyways. But you let
And
me
I
know,
think
and I'll
it
be
definitely will benefit people.
yeah,
So
exactly.
some of the cost things are, at least in the US, are ridiculous.
Right. But
So 8% is the basic cost of the table, and then whatever courier charge is on top, right?
yeah. So
Okay.
in India, it's not more than 400 rupees, where whatever corner of India I send. We'll see what is overseas courier charge. The courier guy. So we are very for all the early bird registrants we had given as a gift.
Right.
And people have started doing procedures on it. So I receive photographs every now and then.
That's great.
So we'll figure out how we can send it across.
હા મને કહેજે તું કારણ કે મારે એટલીસ્ટ એક તો કરવી જ છે
Yeah.
આ લોકોને ગિફ્ટ તરીકે.
Yeah. And you want to ship it to Africa or to US?
Africa, Zambia.
Okay. Yeah. So I'll talk to my courier fellow, figure out what is the charges, and then
If you can do that for me, I would appreciate that tremendously.
Sure.
Yeah. Great. Thank you very much.
Take care. Yeah. Bye-bye.
All right. You too. See you guys.
Bye. Thank you.